So grateful to be here today. And I really I thought I was a bit self-indulgent in preparing this talk, and that I thought, what do I love the most about the research that we do? And what would maybe perhaps have the most implications for the work that you do here at Offord? I know that this is the time of war and turmoil in the world. And, when we reflect upon children and child soldiers and others, really recognizing the impact that trauma, abuse, war service, and other forms of psychological injury have on individuals. So I will start with a warning that some of what I will talk about will be related to war, because that's some of the work that we do. So studying military members, I want people to be aware of that given this sensitive time. So what I'm going to focus on today is moral injury. And moral injury is a concept that really is as old as ancient times. We often think about PTSD as being a fear-based disorder. So one where people are afraid to return to the site of their trauma, where they may be easily irritable or startled. But we think of PTSD and post-traumatic stress injuries in our lab as extending well beyond fear. And we think about concepts like shame and guilt, where people also present with a dissociative subtype of PTSD, where we see a numbing out of arousal, where people are not able to connect easily to others around them, where we see a pattern of, hypoarousal. People are not present in the world, are present in their own bodies. And so work in our lab is really focused on extending that fear-based concept of PTSD to look at other aspects of traumatic injury. And before I begin, I think the most important thing to do is thank the members of the Trauma and Recovery Research Unit, including Krista Andrews, who I saw was on screen as a member of the Offord Center. Really, this screen represents some of the many people whose work I'll be presenting today. And I really want to trace the research with respect to the graduate students and postdoctoral fellows in our lab, because really they are the scientists. I often say I'm the cheerleader to them. So I want to acknowledge and thank them, first of all, for their work. So as I mentioned, I'm going to talk to you about moral injury. And moral injury is a concept that we really consider the signature wound of service. We could think back to Romeo Dallaire and his experience in Rwanda, where he came home and he talked about witnessing the genocide that occurred in Rwanda. And he said, I've spoken to him about this. He said, it's not fear that I struggle with. It's moral injury. And moral injury really reflects the guilt and shame that people may experience around highly challenging ethical situations, or a profound sense of betrayal by an organization or an individual who has a duty of care to them. So in Romeo Dallaire's recollection, he'll say, he felt betrayed by the United Nations because they had a duty of care to him, to the men and women with whom he served, and to the people of Rwanda, and they refused to intervene during the genocide. He also said that he was placed in situations that really violated his own moral and ethical values. So, for example, witnessing the slaughter, and he did eventually bravely stand up to the UN and actually intervene directly. And again, when he came home, he said, I'm not struggling with fear. I'm struggling with guilt and shame about the actions or inactions that occurred in Rwanda, and that profound sense of betrayal that I have around not being supported by the UN and other nations. And this is Ruth Landius, who's a very close colleague of mine, once asked a veteran, what would it feel like if people saw inside of you? And he said, it feels really scary. I feel like they're going to see a kind of stain on my soul. I feel a sense of shame about being in the situation in Vietnam. And I also feel shame about some of the things that I witnessed and I wasn't able to do anything about. So for example, watching idly while they threw a grenade in a hole with a guy and knowing full well what the outcome was going to be. And this reflects his experiences in Vietnam. And he goes on to say, if somebody found out about me, they might run. Previously, I'd been in a PTSD group, and there was one of the other guys in the group who said that when he looked into the eyes of a person who hadn't been in Vietnam, it was kind of like looking into the eyes of a baby. They were just that innocent. And I had that same experience. Part of me wishes that I could get that innocence back. That's something I wish very often. And this is often what we hear from our healthcare workers, public safety personnel, military members and veterans, that they've had experiences that they're uncomfortable sharing with their families. They worry about harming them by telling their stories. They feel that they've lost their innocence, and they're really grappling with this. And we can think back to ancient times where this was discussed for millennia, right? But within psychological injury and neuropsychiatric illness, we seldom talk about it. And so moral injury, again, is that psychological distress that it occurs in response to perpetrating, observing, or failing to prevent acts that transgress deeply held moral standards. And these are some of the symptoms that are associated with this. So we often see re-experiencing the development of negative beliefs, anger, guilt, shame, a sense of betrayal, grief, overwhelming grief, anhedonia, or lack of emotional responding. And when we think about this, we really recognize that there are many symptoms that arise in response to this. I'm sorry, there we go. So I'm going to skip ahead and say that many symptoms arise with this. If we place this in a current context, and this is when the COVID-19 pandemic began, we wrote an editorial for the Globe and Mail back in April of 2020, and we said, our prediction is much of this suffering that healthcare workers and others will experience will be around some of the morally difficult situations that they will find themselves in. We certainly saw that signal emerging in Lombardy, Italy, for example, when healthcare workers were forced to choose who would receive access to a ventilator and who would not. And we interviewed over 150 healthcare workers across Canada, and they provided, I think, some very poignant examples of what moral injury felt like in this context. So describe, for example, beginning futile medical treatments on a patient, which they recognize are unlikely to be successful, but families understandably wanted to hold on to hope. And many described thereby extending suffering and what they felt was prolonging unnecessary treatments. And I will tell you that I served as a psychologist on the ICU units and on the COVID units. And I had people, nurses and physicians in rooms crying with me talking about this. And one actually used the word torture, and I heard that repeatedly. So I think in recognizing the service of healthcare workers in Canada during the pandemic, we really need to recognize the complexity of their emotional experiences. I'm going to talk about some research that we did around that. Other healthcare workers talked about holding an infant who passed away because the COVID rules would not allow the mother into his room, the lack of sufficient PPE for staff, and people also experienced a profound sense of betrayal around this. So that's where we are in Canada right now. But if we look back at the history of moral injury, we can really trace a history that began initially in the military with some work in the healthcare setting. And what I'm showing here is some of the mental health impacts of moral injury, including the onset of anxiety, PTSD, and depression symptoms, ruminating over decisions made, ranging through to increased substance use and suicidal risk. Yet despite knowledge of this struggle with guilt and shame and with a sense of betrayal, this is not characterized anywhere in the DSM-5. So we really have no elucidation of this concept within our current understanding of psychological illness beyond the research that's being conducted. And when people talk about moral injury, they say they have a profound sense of something eating me inside. And people may talk about a nauseating or painful sensation within their bodies, like an internal gnawing sensation. And this is work done by Chantal Lloyd, who was a graduate student co-supervised by Bruce Lanius, myself, at McMaster. And she actually conducted scans with healthcare workers as they recollected morally injurious events. So she scanned their brains while they recollected events that they'd experienced during their service. And this was contrasted with healthy controls who recalled the most difficult situation they had found themselves in within the last 3 years. And what Chantal found that was among individuals, healthcare workers with post-traumatic stress disorder, that they actually experienced what seemed to be a re-experiencing, not only in their minds of the morally injurious event, but also within their bodies. And so people describe this as a gut feeling, a sensation of disgust. And in fact, what Chantal observed was increased posterior insular activation, which is a region associated with moral disgust, with disgust in general, and really reflects that connection between the body or the gut and the brain. It's one of those lower level regions. So that's what Chantal observed among these individuals, which I really think makes that invisible wound of moral injury visible. She also saw increased activation in the dorsal anterior cingulate, which is really, we believe, to be critical to moral processing, to a sense of shame and guilt, and to social pain. And so where did we begin our journey around moral injury? How did we come to this point? I'm going to talk initially about work that we did in the Canadian Armed Forces to really understand experiences of moral injury. And this work traces itself back to Anthony Nazaroff, who was a graduate student in the lab. believe about 10 years ago now, and is actually joining us tomorrow for the Minds Colloquium, is the Associate Scientific Director of the Franklin McDonald Operational Stress Injury Clinic at Center at Western University. So we're very, very proud of Anthony. And Anthony was one of the first people to look at this concept of how do symptoms of guilt and shame relate to post-traumatic stress injury, to suicidality, and again, extending beyond that fear-based conceptualization of PTSD. And we knew at that time that guilt and shame had been widely reported in post-traumatic stress injuries. And in fact, when looking at the common reasons that veterans sought services within the VA in the United States, the most common reason they gave was a profound sense of guilt and shame. And yet when the public typically thinks about military and veteran service, they think about fear-based conditions. And that's often the focus of treatment for these conditions in things like exposure-based therapies, for example. And so what Anthony found in his work, so terrible at advancing this story, was that when we looked at the relation between, this was a scoping review, so it wasn't a study of the military veterans themselves, but rather a scoping review of what existed within the literature. And he found that exposure to morally injurious events and atrocities within war service were highly linked to the onset of increased symptoms of post-traumatic stress disorder, depression, suicidal ideation, but that relationship was mediated by guilt and shame. And so looking within the literature, there was an expression that when I experienced these events, I developed guilt and shame, which was linked to this onset of neuropsychiatric symptoms or suicidality. But again, often not the focus of treatment. So thinking about the work that's done here at the Offord Center, we started to think about who may be most vulnerable to the onset of moral injury, because if we consider individuals like healthcare workers, public safety personnel, military members, and veterans who have a life of service, there's a sacrifice associated with that. That's often exposure, as we talked about, to morally injurious events. This is a very, very small sample. This work was done several years ago, and it was done at Homewood Health Center, where we started to survey inpatients on the post-traumatic stress recovery unit with respect to their childhood trauma, because we really wanted to understand that. And this is a group of only 33 CAF personnel and veterans, and we asked them about their previous history of adverse childhood experiences. This is very similar to Tracy Afifi's work, where she found that, in fact, we see about double the rate of exposure to childhood abuse and neglect among military members. And this is just a simple replication of that. But I think more importantly, what we saw is that exposure to childhood emotional abuse was highly associated with the onset of moral injury. So a sense that I have done something wrong. I engaged in conduct that which I don't consider to be ethical. And also an elevation in a sense of being betrayed as well by an organization or an individual who has a duty of care to you. And if we think back to the work that's been done surrounding how people feel during childhood abuse and neglect, they often develop a profound sense of shame or a schema that I am not a good person. I did something wrong. That can happen. I'm going to show you work from Krista Andrews that really illustrates that. That's what you're taught, right? That you're not a good person. And so when you find yourself in a situation like combat, facing ethical and moral dilemmas, it may reactivate that schema that there's something wrong with me. And moreover, that I have been betrayed by those closest to me, often my family. And here I am when many people join the military for that sense of having a family, of having structure, yet being betrayed again within the context of that service. And so that was work by Alina Protopopescu, who was another graduate student in the lab. And subsequent to this, Anthony, in his new role at Western, along with Bethany Easterbrook, who's a graduate student in my lab, who Anthony and I co-supervise, looked at data collected by Statistics Canada to examine, again, what are the risk factors for the development of moral injury among Canadian Forces personnel. And this is a sample of over 2,000 veterans. And what they found was that, once again, among deployed personnel, exposure to childhood maltreatment, so physical abuse, emotional abuse, and neglect, was highly associated with the development of moral injury, along with the experiences of military-related sexual trauma, which is another area that I work in, which again reflects a profound betrayal, often by a family member, because the person who you would lay your life down for is also the person who's betraying you within these situations. We don't have a lot of time, so I won't go over these additional risk factors, but certainly, again, we're seeing that replication of how childhood abuse and trauma continues to influence the sense of self, essentially, into adulthood. So when we looked again, this is work by Anthony, we really wanted to look at what did moral reasoning then look like among individuals who had experienced childhood abuse and neglect. And this is a group of, I believe, about 45 women who had experienced childhood abuse and neglect. We asked them to reason about very complex moral dilemmas. So for example, you're on board a submarine, the submarine is about to sink, there's not enough oxygen for everyone. If someone were willing to sacrifice their life, then there would be a better chance of survival for others. And when we looked at individuals with post-traumatic stress disorder or post-traumatic stress injury, their reasons for why they made the choices that they made were very different than individuals who had not had this experience of childhood abuse or neglect. The first thing I will comment on is that they often said, you're asked, would you assist in sacrificing someone else's life? It's really like very terrible dilemmas, I will say that. But they said, no, I would not. I would sacrifice my own life to save others because I deserve that. I'm the one who deserves to die. And those are the words that we heard back from many women who had had those experiences. And they often talked about interpersonal approval, the physical consequences, a displacement of responsibility onto themselves, as opposed to people who had not had these experiences who talked about status, normative expectations, so saving the greater good overrules sort of the individual rights, pro-social intentions, and so on. So a very different pattern of moral injury, which I think is influenced in part by those self-schemas that people develop in childhood. Just to flesh that apart a bit more, I'm just going to focus on one graph here in this talk. And this is really when Anthony looked at a similar group of women, and he asked them, and it's a video that's used for training by the FBI in the US to recognize social situations. And what Anthony found was that women who'd experienced this childhood abuse and neglect had a great deal of difficulty teasing apart in these videos who was the parent and who was the child. And I'm sure you're aware from your work that often in trauma, the child often becomes the parent within these situations, right? Caring for someone who's been also being traumatized. And so there's difficulty recognizing that who is the parent and who's the child, despite age-related differences that were apparent in the video. And Melissa Parlar, another student in the lab, looked at this a bit more, and I'm just going to focus on the broad findings here. And what she found was that often there's also an emotional contagion effect among women who have experiences of childhood abuse and neglect, where when they hear about difficult situations that others have faced, they often take on the emotions of those who have faced those situations. So it could be, for example, I might say, my mother is quite ill. And, most people in a professional context, for example, can hear that and say, I'm so sorry to hear that. But often what we saw among women who had experienced this abuse and neglect is that they took on the emotions of others. They experienced them and had difficulty in that separation between self and other. And I think we used to say deficits, which I think is a terrible thing to say. It's an alteration in the way that people experience these sort of situations. And so this is work now by Krista Andrews, led by Krista Andrews. This paper is coming out in traumatology. It's online now. And what Krista did was we had administered, we created a moral injury assessment for individuals who had experienced childhood abuse and neglect. And this could be individuals who had experienced it from the perspective of being the person whom this was happening to, but also parents who were witnessing this within the home. And so we developed a series of questions, which I'm going to have trouble seeing, I apologize. But Krista factor analyzed responses to these scale measures. So we developed a series of questions based on both what existed within the literature, which was very, very little, virtually nothing, then expert consensus, and tried to come up with questions that would reflect moral injury based on the knowledge that we had surrounding this. And we found 4 factors. Krista found 4 factors within these data. So the first was the intergenerational transmission of trauma. And here you can see in the questions, often this is parents or someone present in the home reflecting upon seeing someone else harmed and not being able, powerless essentially, to intervene in the situation. And it's often transmitted through generations. She also saw the emotional sequelae that occurred. So I'm bothered by feelings of self-hatred, fear, shame, sadness. The self-blame. I am bothered that I did not try harder to prevent the abuse that occurred to me. And this is what we often see among adult survivors of abuse, to talk about, I don't understand, for example, why I felt love or affection for that individual, despite what they did to me. I don't understand why my body had that pattern of response in those situations. And it's hard to talk about these things, but I think we do need to talk about it, right? And so people talk with that sense of self-blame. I bothered that I failed to act during the abuse. So it's a common physiological response when you're faced with overwhelming trauma, to freeze. So it's a much like we see this in animals as well, where they're in a situation of inescapable stress and their body freezes and they can't move. They often also dissociate or have that sense of perhaps being above the body, not being present in the moment. And people don't often know why this is happening physiologically and struggle with why did that happen. And we saw that reflected in the responses on this survey. I'm bothered that I kept quiet about the abuse that occurred to me. And so I think when we think about therapeutically, thinking about, we can easily say to someone, it's not your fault. But I think we also need to acknowledge some of the thoughts and feelings that people are having and peel back that onion to explore it with them. People also talked about betrayal. So, and not surprisingly, I'm bothered because I was abused by someone I trust. I'm bothered because I was abused by a family member who should have protected me. I'm bothered because someone in my family allowed that abuse to occur or continue. And so this is a new scale that's been developed by Krista, but I think it goes beyond a scale-based measurement that helps us to attune to guilt and shame and betrayal within the context of childhood abuse and neglect. But I think if we think as clinicians as well, we could explore some of this with our patients and with family members who've also witnessed abuse or neglect of their children, for example. It's a tough topic. It's not easy to talk about. I think it's painful to talk about, but I think often it's also helpful for people to hear that we know their experiences, right? We have the cultural sensitivity to experiences of abuse and neglect that allows us to give people, open up the space for people to talk about very, very difficult things that have happened to them. So on the flip side of that, I just wanted to talk very, very briefly about some work that was done by Sophia Roth. And they were a graduate student in the lab who also worked with Krista on the past survey. Megan Lal, who just finished up her master's, and then Bruno Lozier, who's a colleague at St. Joe's. We also looked at moral injury among offending populations. So among individuals who have been engaged in, for example, abuse and neglect, crimes, essentially. And it was hard to do from the perspective of being, we work on the other side of this. But we wanted to ask, what are the experiences of these individuals as well? And so I don't have time to talk a lot about these data, but just to say that we heard a lot about guilt and shame within this population as well. And often this arises when people gain insight into what's happened. This is not individuals found not criminally responsible. So for example, they may have been in a psychotic state at the time in which, for example, a murder within the family occurred. It's often the case in our setting at St. Joe's where an individual may have, for example, murdered a family member. We hear about this. It's difficult again to talk about, but it just does happen, right? And so people talk about, when I recover from this psychotic state and I know what I've done, how I struggle with how I hurt that other person so badly, that I brought suffering, how I inflicted pain on people. I felt I could have done something different. The thought never came to my head to go to the hospital when I was in this state. And this is a sense of guilt that people are experiencing, which can be contrasted to shame, where guilt is a sense that something went wrong, that we can perhaps change the circumstances and have a different outcome. Shame is an overwhelming sense that there's something wrong with me. I did something wrong. I'm bad. I'm not a good person. I may never be able to change. And when we did qualitative interviews with individuals who were found not criminally responsible, with physicians and others working within the services at St. Joe's and family members of these individuals, they really elucidated these concepts of guilt and shame, which again are not the subject of therapeutic attention. Very seldom. And so we hear people talk about, I did something so heinous for most of my life. I will have this sense of shame. Now I'm not a good person. And so again, these are therapeutic targets that we can engage in recovery for individuals. And we have quite a bit of data, quantitative data as well, but I just won't be able to talk about it today. So this has been part of the journey that we've been on in our lab, and understanding, again, that trauma-related responses are not simply fear. And when we, again, faced the onset of the pandemic, and we were thinking about, what sort of circumstances are healthcare workers in Canada going to be facing? What sort of circumstances are public safety personnel as well going to be experiencing? We really wanted to ask questions about this. We surveyed over 1,100 healthcare workers with quantitative data on their mental health and well-being over the course of the pandemic. We have, I believe, close to 700 public safety personnel who are also well characterized with respect to their moral injury, guilt and shame, symptoms of PTSD, depression, and so on. But I want to focus here on some of the qualitative interviews that were conducted by Kim Ritchie, who at the time was a postdoctoral fellow in the lab, who's now on faculty at Trent. Krista, Bethany Easterbrook, Sophia, Emily Sulo, and Andrea Brown, who's another research associate in the lab. And they interviewed, I believe, about 70 public safety personnel across Canada, 150 healthcare workers. I should have the numbers here, but I thought it was more important to talk about the concepts across the country, talking about their experiences during the pandemic. And much like healthcare workers, we saw the onset of moral injury among public safety personnel as well. Oops. And so this is actually work that we had done prior to that at Homewood Health Center. So we had interviewed close to 100 public safety personnel, military members, and veterans who were receiving inpatient care at Homewood Health Center. And we asked them, what is different about the experience of post-traumatic stress injury within the context of being a public safety personnel, so fire, police, ambulance, paramedics, or military members and veterans? What's different, and what do you need from your care team that is different from what you see in the care being administered to civilians who are also here on the unit? And this is a quote from one of the first responders, and he or she talked about, it's about moral injury. It's not just one trauma. I liken it to, it's like getting that little rock in your shoe where you can walk 10 steps and kick it out, and it's okay, 10 more steps and you get another pebble in your shoe. You do that over 10 years and you walk around with these pebbles in your shoe. It's going to irritate you after a while. And that's what I find in my experience. That's what kills me. It's some of those big things that are the straws that break the camel's back, but sometimes it's also the small. And so he's talking about that accumulated burden of exposure to ethically challenging situations. And as we'll see in the data that we've collected, also that sense of betrayal at times by a government, by an individual, an organization that they feel because of their service has a profound duty of care to them. And so when we looked at the major themes that emerged within these particular interviews, again, asking, what is it that's different about an experience of post-traumatic stress within the context of being a public safety member, a military member, a veteran? And they talked about a number of different things. So the changes in identity, so changes in social identity, often going from seeing themselves as someone who was not a public safety personnel to this being all-encompassing as part of their life. They don't often necessarily want to be around individuals who are not PSP because they feel that they live in a different world, right? And it's like we talked about the veteran at the beginning. It's like looking into the eyes of a baby, sadly, even my family, because they don't know the experiences that I've seen. They also talked about some of the mental health toll, the impact on the pervasive impact on relationships with families, friends, the public. We're seeing public often is, I've seen so many bad things. When I see a member of the public, I become suspicious of them without knowing. And people often talk about that, unfortunately. That's a change in your sense of self, of who you are, right, as a person. And they also talked about that moral injury that they experienced. So this came out very strongly in the interviews that public safety personnel talked about, feelings of guilt and shame, betrayal, and anger. And anger is really a secondary emotion, right? It often arises from some other emotional state, which could be betrayal, shame around oneself. And when we talk to Veterans Affairs Canada, they'll often say that one of the most resistant facets of mental health treatment-resistant facets of mental health within veterans is anger. So struggling with anger at the system, anger at the government, anger with the situations that they found themselves in. And we would argue that often that comes from that underlying sense of betrayal, right? Or shame or guilt that they may be struggling with. And so this was sort of a preliminary signal. And other people have also looked, of course, at moral injury and public safety personnel, but it wasn't so much of a concept at the time. And so again, Sophia, Krista, Alina Protopopescu, and Chantal Lloyd looked at data from a scale that we had created to assess moral injury among public safety personnel. And when they factor analyzed this particular scale that we had created, they found that some of the factors that emerged was a sense of job-related perpetrations. So witnessing morally distressing situations that were made on the job that they really struggled with. There was one key example that we heard in the interviews where first responders are no longer allowed to intervene during a drowning if the person is X amount of space from the shore, right? And so they were talking about, for example, having to stand on the shore and witnessing someone drown and wanting to intervene and being held back. And I don't think any one of us would want to find ourselves in that horrible situation, right? And so people talk about witnessing these morally distressing decisions, having to protect self over other. So for example, if a building is on fire and there are children inside, but having to make the decision to pull out the first responders because they will likely lose their lives because the building is about to collapse. And, you know, I've talked to first responders who talk about this. This is what they struggle with, many of them. There are situations where, in triage situations, where one life is lost to save another who's more likely to survive. They also talked about institutional failings, so perceived moral violations by a governing organization, vision of insufficient training, a lack of support and recognition for their sacrifice and their service, and then the emotional impact upon them. So the emotional sequelae that result from job-related moral violations. So again, that anger, shame, and guilt. And so again, we're seeing a signal that's similar in a way to what we saw among individuals who had experienced childhood abuse and neglect, with the institution or the betrayal from somebody who has a duty of care to you, the emotional sequelae of the guilt, the shame, and the anger, and then being faced with very ethically challenging situations. And so this was just published, and we're hoping that it will be used to identify moral injury within public safety personnel. These are just some of the questions, which I think in the interest of time, I can send out the slides, but I think in the interest of time, we'll just move on from the questions. But this is how they analyze the factor analysis that we did on the questions that had good item loadings to create the scale. So from a psychometric perspective, which items perform well on the scale. And you look at those items and then you factor out the subscales, which is essentially the factors in the factor analysis. And so I think Sophia then had a really terrific idea where they said, I want to look, going back to that earlier work that we did, looking at the relation between childhood abuse and neglect and the onset of guilt, shame, a sense of betrayal, or essentially moral injury. Well, she asked, how did exposure to childhood events impact on the development, again, of moral injury, post-traumatic stress symptoms, and other trauma-related symptoms among public safety personnel? But is it more of is that also moderated by other factors? So could you experience adverse childhood events and yet not be more vulnerable to the development of a moral injury? And what are some of the factors that would contribute to that protective effect? And so when Sophia looked at these data, this is a mediation moderator analysis, but what I really want to say is that what this shows is that, well, as we know, adverse childhood experiences are highly associated with the onset of trauma-related symptoms, including dissociation, and depression, anxiety, and post-traumatic stress injury. Moral injury seems to be one of the pathways by which these symptoms emerge. But looking at the mediation moderation analysis, for individuals who have high levels of emotion regulation skills, so recognizing and identifying emotions, having strategies to deal with those emotions, they are in fact less vulnerable to the development of moral injury, and by implication, the development of post-traumatic stress injuries and so on. When individuals haven't had likely those attachment relationships which model for them recognizing emotion, developing strong emotion regulatory skills. And we didn't measure attachment here, so that's a supposition that I'm making. But low levels of emotion regulatory skills are associated with the development of moral injury and the subsequent development of post-traumatic stress injuries, depression, anxiety, and stress. So this is one of those days when somebody just comes to your office and says, like, wow, look what I found. And that was sort of Sophia. She said, or they said rather, I looked at these data and look at what I found. It was really incredible. So I really want to credit them for this work, and Krista, who was also involved in this. And I think it really helps us to extend our understanding of the pathways by which moral injury develop in the face of a history of childhood abuse or neglect. It also provides therapeutic targets as well, as we again unpack that onion, right, to fully understand what's happening here. So going back further to the issue of public safety personnel, those are data from a sample of public safety personnel. We certainly knew, and I've already talked about the healthcare data at Research Day, so I chose today to focus on public safety personnel. We have very similar findings in healthcare workers, but I wanted to focus on something different today. And so we know that public safety personnel over the course of the pandemic were really facing a fear of bringing COVID-19 home to their families, much like healthcare workers. They were also faced with ambiguous and constantly changing policies and practices that were governing their work practices, which is just what we saw in our healthcare settings. And they were also charged with enforcing controversial public health measures that were enacted properly to reduce the spread of infection, but often faced controversy within the public. And so I'm going to talk here about interviews that were conducted with dispatchers, correctional officers, paramedics, border patrol, firefighters, and police across Canada by Kim and other members of the team. And these interviews occurred from June to December 2021, so in the onset of the Omicron phase of the pandemic. And so one of the themes that came out in these data was the moral and ethical values of public safety personnel. So they talked about the integrity, honesty, the paramedic firefighters saying patient care, having each other's backs. Everyone has the right to be themselves authentically. We're trying not to harm people in the work that we do, and we care. We entered into these professions because we want to help, much like healthcare workers. But when we looked within a thematic framework of how are these individuals impacted by potentially morally injurious events, we found 3 different levels of moral distress or moral injury that apply to individuals themselves as a person, to the team level, to the organization and systems level, and the public level. And one thing I want to say is that oftentimes when we think about post-traumatic stress injuries or moral injury, the blame is often placed upon the individual, right? We say that this person has developed post-traumatic stress injuries, this person is struggling with guilt, shame, and anger. But we often, and I would say almost always, neglect that operational or organizational systems level. How do we change the organizations and systems around people so that they will be less put into situations which confront ethical and moral values, or where they feel betrayed by organizations or individuals with a duty of care? I know we don't have a lot of time, so I'm just going to talk about some of the examples. So this is a person level moral injury and failure to prevent harm by following COVID protocols. And just to sum this up, we heard from many public safety personnel that, particularly paramedics, that when they were responding to calls during the pandemic, they would have to stop to don PPE. And what would often happen in that interval when they arrived at the call was that somebody would be in acute distress, for example, having a heart attack. And in the time that it took them to don their PPE that were necessary to respond, people were losing their lives because there wasn't sufficient time to intervene. And we heard that over and over and over again, where dispatchers were getting calls to deploy an ambulance or deploy emergency services, particularly in the West, and there was no one to send. Right? So you can imagine being on the phone with a distressed family member. The Canadian public has an expectation, of course, that we will receive emergency care, and that these individuals were faced with many situations where there was no one to send. We also heard about the impact on teams where, for example, some members of teams did not want to mask, they didn't want to follow vaccine mandates, and people were saying, it really changed the way I felt about my team members. It so offended my fundamental values that people would not do this, particularly when we're in a helping profession. And the corollary of this, which emerged, was that people felt like their team members no longer had their backs, that there was a fracture within the team because of this. And when you're going into a high stakes situation where you need the person beside you to help you, to potentially save your life, if you don't have that trust, then how do you operate within these very risky environments? They also talked about organizational or system level variables. So if I felt a patient needed the treatment, I still did it, and I dealt with the consequences. So this is what we often see at Homewood, is that we see public safety personnel who have been disciplined for actions which they consider to be ethically correct. Right? And they end up in the system, and it often results in or triggers some of their symptoms of post-traumatic stress injury. They also talked about the public, and this was very pervasive again. So patients would lie, this is again a paramedic, and say, I don't have COVID. But in fact, of course, they did have COVID. And so they learned not to trust the public, and also felt a lot of anger towards the public in some instances, because I'm putting my life at risk, I'm putting my family members' lives at risk, and you can't even wear a mask. So we heard that repeatedly. That's the way they would characterize it over and over again. Why is the public not acting to protect me when I'm making this sacrifice to protect them? So what did this translate into? Well, a sense of anger and frustration, disappointment, a sense of powerlessness, not trusting the guys that they would pull me out. And this is a profound alteration within the individual, but also within the teams. And so I wanted to say, why is this important? Well, a couple of things. So when we looked at healthcare workers across the country, we found that initially during the Delta phase, 1 in 4 were screened positive for a probable diagnosis of PTSD. Very similar numbers among public safety personnel. And by the Omicron phase of the pandemic, where we saw initially during Delta, 1 in 4 Canadian healthcare workers were considering leaving their clinical positions. By the time we got into Omicron, it was 1 in 2. And these numbers seem pretty consistent. And when we explored why they were considering leaving their position, the variable that soaked up the most variance in the regression model was moral distress. So high levels of moral distress attributed with their pandemic service, including a sense of betrayal. And these are just some of, I've talked about this at research day, so I'm going to skip ahead. But to say, we then constructed models that would look at what predicted the onset of post-traumatic stress injury among these healthcare workers. And we found that moral injury and moral distress is a combined variable. So moral distress may not reach the level of moral injury, but you're having distress in association with your actions or what you're witnessing or the sense of betrayal. It accounted for 87% of the variance in the onset of post-traumatic stress injury symptoms among Canadian healthcare workers. And when we looked at what are the factors that decrease moral injury among Canadian healthcare workers, what are the protective factors? We found 2. So one was increases in perceived organizational support. So when organizations support their workers, we see a decrease in moral injury, and also spirituality and religiosity among these individuals as well was also protective. So would argue a couple things. I think that, again, PTSD extends beyond a fear-based condition to encompass guilt and shame, moral injury, that this is predictive of the onset of illness, that we can act to decrease, in some instances, that we can act to decrease moral injury by providing, for example, high levels of organizational support. So a couple of weeks ago, we put in a grant to CHR to develop trauma-informed organizational support policies within hospital settings. So we're going to trial this if we are funded at St. Joe's to really enact these principles as a proof of principle, and then to see changes potentially among healthcare workers and their mental health and well-being, and then to try to disseminate this. That's one of the projects that we want to be working on. But I think from the perspective of mental health and well-being, also thinking about whether moral injury should be a qualifier in the DSM, in the next version of the DSM. So we would argue not that this is necessarily a separate syndrome, because we see it emerge in depression, post-traumatic stress injuries, anxiety. It's not just limited to people who have post-traumatic stress disorder per se. It occurs across a host of different neuropsychiatric conditions. And so much like we have qualifiers for other variables, do we need a qualifier for moral injury as well? And that's the question that we would ask. And we need, of course, field trials to look at that and many other things, but I think that's the fundamental argument that we would make in the end, is that this really is a profound part of human experience that can drive mental health and well-being. So I'll conclude on that note. Thank you for your patience. This is all your funders and